Tell me, Rasdeep, tell me.
Yeah, this is regarding cystatin based in EGFR,
Yeah.
right? My question is very simple. Shouldn't we replace the EGFR creatine based to cystatin based in a routine practice? What is your take on that? Because we know there are a lot of issues with the creatine based, whether the patient is
Yeah,
weight
yeah,
is
yeah, 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 absolutely. That is the reason why we need to see the both creatinine based EGFR and the cystatin C based EGFR. Like, I want to quote an example here, Rasdeep. Fructosamine was there. We used to use fructosamine before the HbA1c is coming to vogue. Do you remember that?
yeah, yeah.
Yeah. So now fructosamine we rarely use, and we use it if at all it is used in cases of GDM. Beyond that, there is no role for fructosamine actually. We go for only HbA1c. Just like that, the days are going to come where the creatinine based EGFR is totally replaced by the cystatin C based EGFR. But as of now, you need to take the both. If you have the facility, both should be taken, both should be conveyed.
So, or should we restrict this who has a CKD in the range of 45 to 59 in patient without albuminuria? Then we go for cystatin based. In context to Indian scenario.
See, Indian scenario, it is a little bit difficult to take this cystatin C based because most of the places it is not available actually. So the
Yeah, I know that.
simple see to be honest with you, say the India is no exception. The patients all over the world are same. We need to take both, but where the facilities are not there, at least we need to calculate the EGFR because creatinine is totally a decisive figure. Just by creatinine, the days have gone. Earlier, we used to teach like 1.5 of creatinine stop metformin. That and all is trash now. See, it's ridiculous. We get back to the situation around 20 years ago. Now we started calculating. There are multiple the apps on the internet, so that we are very easily calculating the EGFR because EGFR gives you the exact figure where you can stage the diabetic kidney disease or the chronic kidney disease or the chronic renal failure or the diabetic renal failure, whatever it may be. If at all you want to stage it 1, 2, 3, A, B, 4, 5, you need the creatinine based EGFR, which is available all over the country. You just have to have the serum creatinine, that is male or female, the African American or others. That's it. Okay, these are the parameters, and that's it. Age,
So that means
creatinine,
you.
age.
So that means you are recommending both creatine based plus.
Yeah, both. You should compare with creatinine based EGFR and the cystatin C based EGFR, which is more refined when compared to the creatinine based EGFR.
So we classify based on the if we do it both in the patient.
Yeah.
I'm just talking as a practical issues in a day-to-day practice, right?
Tell me.
If we're doing both the tests, both I mean creatine based and
Cystatin based.
so
Okay.
we classify CKD based on the cystatin C base. That's what you're saying.
No, we are not. We see as of now, we are not classifying the patients on the cystatin C based EGFR. We are classifying on the creatinine based EGFR only. The present system of stage 1, 2, 3, A, B, 4, 5. That's it.
Okay, so that means
You got the point, Razi?
yeah, I got the point. That means
Yeah.
creatine based we
But
cannot ignore at the
yeah. But serum creatinine varies a lot when the patient is dehydrated, so it shoots up.
That's what I'm saying. Like
See that's it. That's what I said. It's a decisive parameter, but still then we don't have other go. Like okay, you don't have the cystatin C levels. At least you should have this particular. On 2-3 occasions you can have this. Okay, when the patient is adequately hydrated, you can take the creatinine.
My question is especially for the elderly who are not taking an adequate diet or who are.
Yeah, that's what. Whatever it may be, the staging doesn't differ whether the patient is elderly or whatever it may be, but To be honest with you, you need to have some 2-3 readings of the serum creatinine on different days. You can just take the average. That's it. Okay.
Okay, I got it.
Not all cases are decisive. Not all cases are false creatinine levels.
Okay. And second, very small
Might be a case of AKI. See,
Oh,
acute organophosphorus poisoning, snake bite, or the scorpion sting. The patient might just even simple the gastroenteritis. The patient gets into acute kidney injury. Doesn't mean that it is a chronic kidney disease, right? Okay, you cannot compare the like this with that of the CKD or DKD. You cannot stage in AKA. That's it.
okay. Yeah,
Yeah.
got it. Got it.
Yeah.
And one last question on OSA.
Yeah.
See, like this is a very complicated to understand what is the etiology of the OSA in diabetic people, right?
Yeah. It is complicated, but it is well known that obesity is the root cause for this particular whether it is plus diabetes or minus diabetes. Obesity is the main cause actually,
That's right.
and the obstructive sleep apnea syndrome. If it is not evaluated properly, the sleep solemnography studies and all, it becomes very lethal. That's it.
I know that. So,
The apnea will take away the patient. So wherein you need either the CPAP or the BiPAP.
so the patient who is already diabetic and who has OSA using CPAP, like you're talking about the empagliflozin molecule. that
Yeah.
is Initially, do you have any molecule which can the patient who is already having OSA using CPAP? Do you
No,
recommend this
there
molecule?
is no molecule for this particular OSA, and the OSA has to be handled with special care because the patients with OSA are more vulnerable to get the acute myocardial infarction attacks. They do die of the CAD.
Mhm.
So the sleep studies and even the angiogram should be done very meticulously, very methodically, and either the CPAP and see, the only thing is it is that don't ask the patient to lie down straight and all. The supine or prone and the left lateral, right lateral is much efficacious, and the therapeutic lifestyle changes like diet, exercise, reduction of weight, cessation of smoking, and cessation of alcohol is going to give you the best results rather than the CPAP or BiPAP or the empagliflozin.
Great, thank you. And
Even
last question.
even in the one more addition, even in the liver disease also, whether it is
Okay.
NAFLD or MAFLD or the metabolically deficient associated steatohepatic liver disease, even also the weight reduction is more important. What I said, all the diet, exercise, they are more important than the drugs like pioglitazone or the this particular the metformin or the SGLT2 inhibitors, DPP inhibitors, phenofibrates and the statins and the saroglitazar. You name a thing, the vitamin E, 400 milligram BD, anything. You combine all, they are even lesser than this particular weight reduction first. Weight reduction itself leads to the reduction in the fat in the liver cell actually. Yeah, tell me, Rasdeep, you were asking me something.
One last thing.
Yeah, don't say last. Keep shooting the questions. Okay.
This ADA, I was reading the ADA 2024 guidelines. Right?
Yeah.
It hasn't mentioned about the very important molecule, especially in the context of India, about the glycoside, because it's an important alternative. Those who have a cardiovascular disease and
Absolutely. Yes. A very valid question raised.
we're giving a combination of metformin with a glycoside, I mean diamacron XR with a
Yeah. See.
and dapagliflozin.
Yeah, wonderful. Now there is one company that has come out with dapagliflozin and glycoside.
Okay.
And one more thing I tell you, Rajdeep, the peculiar aspect of this glycoside used in plain preparation, like the like alone glycoside, not extended release or the modified release or the sustained release. Only the benefit you get with the XR or SR or MR, modified release.
Yes, I know.
The cardiovascular defects, and this is one molecule can be used in any stage of the CKD or DKD actually.
Yes.
Like linagliptin, but with a very little dose, because of the it's a secretagogue, it always squeezes out the insulin, and CKD always there is stagnation of this, all these things they will not be sent out. The patient gets into unexplained hypos. That's it. That is how we clinically elicit the unexplained hypos. Even the patient is doing extraordinarily good. Any patient complains of unexplained hypoglycemias, you should clinch the diagnosis. Brain should click the diagnosis of CKD, and you should rule it out very immediately. Like you find the tall peaked T waves, you have to rule out hyperkalemia. That is dictum. That's it.
Okay.
Any questions, Rajdeep? Very happy that my friend has joined my webinar. Good. Welcome, Rajdeep.
Thank you. And similarly, you've taken a seminar for an dapagliflozin, a detailed one also.
Yeah, absolutely. I am clinically unbiased. Okay. Absolutely. I'm not biased.
Thank you. It's a great presentation.
Yeah, thank you. I had to rush up because there's so many studies are there, and so many bar diagrams, graphic representations, which have to convey the message. That's it, Rajdeep. So, are there any other questions?
Sir, we have two queries, sir. One is initial follow-up in EGFR with SGLT2 inhibitors. Is it something of concern? When we should intervene?
See, it is a physiological phenomena that the initial fall in the EGFR in the first 2 to 4 weeks by 10 to 20% is a very physiological phenomena. You don't need to worry about it. Even it goes below 30, 20 also, don't worry. You just continue. Later on, you don't need to intervene at all. Just don't stop the molecule just by seeing the scary EGFR. Just continue that. It keeps raising the EGFR in the long run to come. Don't stop empagliflozin, please. Second question. You said two questions, right?
Yes, sir. Second question is, can gliflozin be used instead of pivixostat if patient has raised uric acid, patient is euglycemic?
Acha, when the patient is euglycemic, he's got hyperuricemia, gout, can empagliflozin be used instead of febuxostat or allopurinol? Absolutely no. When the patient is non-diabetic, there is no role. It is an additional benefit of this if it is used in type 2 patients, because the triad which is very important is type 2 diabetes and the hypothyroidism and the hyperuricemia, they go hand in hand. So whenever the patient has got the type 2 diabetes, you start empagliflozin. If the patient eventually has got hyperuricemia or the clinical gout with symptoms, the uric acid levels go down very significantly with this. It is an add-on therapy, like the add-on therapy to either febuxostat 40 milligram or 80 milligram, or the people who are very fancy about still using allopurinol 100 milligram TID. It's only always an add-on therapy. Like I said, the resistant hypertension, it's a very good add-on therapy to the standard care of resistant hypertension. It doesn't mean that you stop all the antihypertensives, you use only empagliflozin, resistant hypertension is closed. It is the patient that is getting closed, not the resistant hypertension. So it can never be used in the absence of diabetes. The only to condition wherein it can be used, the empagliflozin is the dapagliflozin is the pre-diabetes. The recent the studies have rolled out that apart from until then only lifestyle modification, therapeutic lifestyle changes, and only this particular the metformin in pre-diabetes. But now that you can use pre-diabetes, this particular metformin and SGLT2 inhibitors also. But for that, no role. You cannot use it as a slimming agent. It reduces 5 to 10 kilos. I have seen in my clinical practice. It doesn't mean that it is not a slimming agent. You cannot use it, okay? Any questions, please? You can unmute yourself and ask me.
Yeah, no question, sir.
Yeah, no questions. Thank you so much for your patient listening. Thank you, dear my friend Rajdeep Srivastava, a good friend of mine from the last 42 years, Rajdeep?
Yeah, Krishna.
42 years of friendship. Like,
Thank you, Krishna, for your such a beautiful insight. And never mention about the ADA guidelines. They are very confusing.
you always say Krishna's guidelines, okay?
Yes, you mentioned your guidelines only. Very crisp.
Thank you so much, Rajdeep. Lot more to talk to you personally, okay?
Okay,
See you
thanks,
then. So, if there are no questions, Ramesh, please wind up this session, okay?
Okay, sir.
And thank you so much, my dear professional colleagues, for your patient listening and for your wonderful interaction. And also, I thank Boringa Ringalam people for giving me an opportunity to be the speaker of the evening. Please, thank you.